G6PD deficiency, or glucose 6-phosphate dehydrogenase deficiency, is a genetic disorder impacting the G6PD enzyme, crucial for the pentose phosphate pathway. This pathway is vital for protecting red blood cells from oxidative damage by generating NADPH. Without sufficient G6PD, red blood cells can't combat oxidative stress effectively, leading to their premature destruction, known as hemolysis. Understanding this deficiency is key for healthcare providers to manage and treat affected patients effectively. G6PD deficiency is inherited in an X-linked recessive pattern. Males with one mutated X chromosome express the disease, while females require mutations on both X chromosomes to exhibit severe symptoms. The G6PD gene, located on the X chromosome, XQ28, encodes the G6PD enzyme. Mutations in this gene reduce the enzyme's activity, impairing the red blood cell's ability to detoxify reactive oxygen species. This enzyme plays a crucial role in the pentose phosphate pathway, which generates NADPH. NADPH is essential for maintaining the reduced form of glutathione, which detoxifies reactive oxygen species in red blood cells. Variants of the G6PD gene are classified based on the enzyme activity level, with Class I being the most severe and Class V the least. The G6PD enzyme is crucial in the pentose phosphate pathway, which provides NADPH, a cofactor for reductive biosynthesis and antioxidant defense. NADPH maintains the levels of reduced glutathione, which detoxifies hydrogen peroxide and other reactive oxygen species. Deficiency in G6PD disrupts this balance, making red blood cells susceptible to oxidative damage and hemolysis. During oxidative stress, such as infections, ingestion of certain foods, or medications, the red blood cells undergo oxidative damage. This leads to the formation of Heinz bodies, which are aggregates of denatured hemoglobin. Heinz bodies can be seen as dark inclusions within red blood cells when stained with special dyes. The presence of Heinz bodies makes red blood cells more rigid and prone to destruction by the spleen. As the spleen filters out these damaged red blood cells, it results in the formation of bite cells. Bite cells, or degmachites, are red blood cells with portions removed by splenic macrophages. The appearance of these cells on a blood smear is a hallmark of oxidative hemolysis in G6PD deficiency. This process of hemolysis leads to a decrease in the overall red blood cell count, causing symptoms of anemia. The severity of hemolysis and anemia depends on the degree of enzyme deficiency and the level of oxidative stress. G6PD deficiency affects an estimated 400 million people globally, with varying prevalence across different ethnicities. It is most prevalent in malaria endemic regions, suggesting a selective advantage against malaria. African populations, prevalence can be as high as 25%, particularly in sub-Saharan Africa. This variant often leads to milder symptoms. Mediterranean populations. Countries such as Greece, Italy, and Turkey have a significant prevalence, with some variants leading to severe hemolytic anemia. Middle Eastern populations. Prevalence is also notable, with many affected individuals carrying variants that can cause severe symptoms. Southeast Asian populations. This region, including the Philippines, has a high prevalence. In the Philippines, approximately 6 to 10% of the population is affected. The Filipino variant of G6PD deficiency can vary in severity, and understanding this is crucial for providing appropriate care. Understanding the demographics helps in anticipating and diagnosing the condition in diverse patient populations. In the Philippines, efforts to screen newborns for G6PD deficiency have been implemented to manage the condition early and effectively. The clinical presentation of G6PD deficiency ranges from asymptomatic to severe hemolytic anemia. Common triggers include infections, certain foods, and medications leading to oxidative stress. Symptoms of hemolytic anemia include jaundice, dark urine, fatigue, pallor, and shortness of breath. Neonatal jaundice can also be a presenting feature. In severe cases, patients may develop acute hemolytic anemia, characterized by rapid onset of hemolysis, leading to anemia and hemoglobinuria. Laboratory findings include decreased hemoglobin, reticulocytosis, elevated lactate dehydrogenase, LDH, and decreased haptoglobin. G6PD activity assay is used for definitive diagnosis, though testing should be done when the patient is not in an acute hemolytic state, as reticulocytes have higher G6PD levels than older red blood cells. Certain foods and medications can trigger hemolysis in individuals with G6PD deficiency. Fava beans, also known as broad beans, contain vicine and convicine, compounds that induce oxidative stress. This condition, known as favism, is particularly common in Mediterranean populations. Medications that can trigger hemolysis include antimalarials, primaquine, and other quinine derivatives, antibiotics, sulfonamides, dapsone, and nitrofurantoin, analgesics, aspirin, and certain NSAIDs. Others, methylene blue, respiricase, and certain chemotherapeutic agents. Healthcare providers should carefully review medication lists and advise patients to avoid these triggers. Additionally, infections can increase oxidative stress, so prompt treatment of infections is crucial. The cornerstone of managing G6PD deficiency is the avoidance of known triggers. Patient education on avoiding certain foods, medications, and managing infections is essential. In acute hemolytic episodes, supportive care includes hydration, ensuring adequate fluid intake to prevent renal complications, oxygen therapy for patients with significant anemia and hypoxia, blood transfusions in severe cases of hemolysis and anemia, folic acid supplementation to support erythropoiesis. Long-term management includes regular monitoring of hemoglobin levels, reticulocyte counts, and G6PD activity. Genetic counseling may be beneficial for affected families. Ongoing research aims to better understand the molecular mechanisms of G6PD deficiency and develop targeted therapies. Gene therapy and enzyme replacement therapy are areas of active investigation, with the potential to provide long-term solutions for affected individuals. Advances in genetic screening and personalized medicine may improve early diagnosis and management, reducing the burden of this condition.